you very much. So there is some overlaps. We'll run over that overlap briefly, but we're going to be talking about the genetics of short QT syndrome. As we discussed in the earlier afternoon, there's a typical phenotype of tall peak T waves, a short ST segment, and a narrow QT. This is a study that was in JACC, really a retrospective review of all of the published cases of short QT syndrome, and they were identified 61 patients that had short QT, 75% of them were male. Average QTC was about 307. 26, or about 43% of them were asymptomatic at presentation. 18% had AFib. 25% had an aborted cardiac arrest, which is a really high incidence relative to the other cardiac channelopathies that we know of, and 8% experienced sudden cardiac death. So the genotype information of these patients is rather interesting in that the short QT syndrome, again discovered by, in part by Dr. Brugada, showed a mutation in the KCNH2 gene that 10 patients had in this study in 3 different families. This is the most common gene mutation in short QT syndrome, and the rest is really a smattering of individual cases, more or less. 2 other KCNH2 genes were found with really only 4 patients between them. KCNQ1 genes in short QT2 syndrome had 1 of each really in these 2 mutations. And then finally, short QT3 syndrome, there were 2 cases but in 1 family. The remaining 44 patients were genetically elusive. This suggests that there are more that meets the eye than these 3 genes seen here. Which brings into question the role of really genetic testing in this, at least as it stands right now, which is why I show the diagnostic criteria for short QT syndrome. For those of you that are familiar with the long QT syndrome diagnostic criteria, the Schwartz criteria, this is really synonymous in that you have different scores depending on the severity of your QTC shortening, where less than 330 is quite rare and buys you nearly the diagnosis of short QT syndrome alone. J point T peak interval that's really shorter, an ST segment that's absent counts as a point. Clinical history of having an arrest, AFib, unexplained syncope. Family history, of course, is important. And then finally, genotype, being gene positive gives you 2 points. Having a mutation of undetermined significance in any of the genes that we discussed gives you 1 point. You're considered low risk at 3 points, intermediate at 4, and high if you're greater than 4. So again, genotype is part of this diagnosis, but given the amount of elusive patients, there's still a lot more phenotypically that we look at in this. But to examine the short QT subtypes, there are really 7 that we know of to date. And this is adapted from Dr. Ancelovich. Short QT syndrome 1 has the shortest QTC at 280. These patients are the most phenotypic, and again, this is the first one discovered, and the mutation is in the IKR channel. Short QT syndrome 2 is KCNQ1. Short QT syndrome 3 is KCNJ2, and so on and so forth. We'll dissect these individually. But the common theme here, as Dr. Brugada discussed, is the concept of the action potential and the effect of the ion channelopathy on that action potential. So as you see in this, you have the action potential and the EKG below it. The concept of hyperrepolarization comes into play with either sodium channelopathy at the beginning phase of depolarization, phase 0, or hyperactive repolarization, where there's a gain in function in these potassium ion channels, thereby shortening the QTC interval. Essentially, this is the opposite of long QT syndrome from a functional standpoint. Short QT syndrome 1 affects the IKR, which is a delayed rectifier potassium current. I've written here that it affects phase 2. It also affects phase 3. It's a gain of function mutation, and this nucleotide substitution is the most common mutation type seen. Short QT syndrome 2 affects the IKS, the slow delayed rectifier potassium current. It's also a gain of function mutation. a little later in the repolarization phase. First described in a 70-year-old male who had a VF arrest. This KCNQ1 mutation, by the way, is the same mutation that's associated with atrial fibrillation, so there's overlap. The short QT3 involves the KCNJ2 gene, and it's the IK1, which is the outward potassium current in repolarization, and it's also a gain-of-function mutation. First described in a 5-year-old child and a 35-year-old relative, his father. The father had very odd sudden awakening and seizure-like activity during sleep. Again, atypical syncope is sort of the hallmark of short QT syndrome. If you look at, this is probably one of the few genotype-phenotype correlations in short QT syndrome. This is the KCNJ2 gene here, and if you look at, I'll go back to the phase of repolarization that's affected. It's the late phase of repolarization, which really translates on an ECG here to asymmetric T waves, where there is a sort of a normal upslurring of the T wave, but a very rapid repolarization phase because of that sodium channelopathy that's affected. And you see that in the other patient too, the relative. And their QTCs are quite short. Short QT syndrome 4 and 5 we've lumped together. These are both calcium channelopathies. Short QT syndrome 4 affects the KCN A1C, which is the alpha subunit of the calcium ion channel. Short QT syndrome 5 affects the beta subunit. These are loss of function mutations that cause abbreviation of the action potential and an ST elevation. This all sounds familiar because this is phenotypic overlap with Brugada syndrome. And as you might imagine, if a baseline ECG looks relatively normal under adrenaline influence, you see that you pronounce the right bundle, ST segment elevation, phenotypically again looks like Brugada. So what are the unifying themes in all of these genotypic syndromes that cause short QT? And really this is, to reiterate what Dr. Brugada discussed, these all cause a hyperrepolarization in either IKR, IKS, or IK1 in the action potential repolarization phase, thus shortening the QTC very logically. Alternatively, short QTC causes decreasing depolarizing currents in sodium or calcium, which decreases the plateau of depolarization, and by abnormal gating and repolarization causes shortness of the QTC interval as well. Finally, dispersion of repolarization and refractoriness. This is really a common theme in all of the ion channelopathies. This is the substrate for unidirectional block, the substrate for reentry, the substrate for torsades. To illustrate that a little bit better, this is an example of long QT syndrome, but the concept still is valid. You see here is the ERG channel mutation causing a decreased function in IKR. The dispersion causes certain parts of the cardiac myocyte to be depolarizing, certain portions of the cardiac myocyte to be repolarizing. And that discrepancy in depolarization and repolarization causes reentry. The theme in electrophysiology is proximal delay allows for distal recovery. So if you have different parts of the myocardium behaving differently electrically, and you impulse an early after depolarization potential, an action potential that doesn't quite cause a normal depolarization, but through reentry processes can activate the myocardium, can pull on the QTC, can cause torsades, and these are all the mechanisms of dispersion of repolarization, something Dr. Brugada describes very eloquently in papers in Brugada syndrome. So what is the state of genetic testing? What are the recommendations? This is by Ackerman through the Heart Rhythm Society and the European Heart Rhythm Association consensus statement in 2001. They state that comprehensive short QT testing for the mutations described may be considered for any patient whom a cardiologist has established a strong clinical index of suspicion for short QT syndrome based on evaluation. Mutation-specific testing is recommended, though, for family members, so cascade screening is still something that is indicated. Though this that may be considered, if you're familiar with the consensus statements, is very soft language. For long QT, for CPVT, the indication is much stronger. And as Dr. Brugada mentioned before, I think the dropout here is the identification of patients with this syndrome. We just don't have enough to establish genotype-phenotype correlation. We don't have enough genotype patients to know all of the genotypes that are involved in short QT syndrome. And hopefully that's the future direction, that short QT syndrome really follows the path of long QT syndrome in the sense that there's increased recognition, more genotype-phenotype correlation. We can risk stratify with genotype information, and that obviously will guide mutation-specific therapy. I don't know how long we are from this, but hopefully we're going to get there soon. Thank you.
Thank you very much, Gordon, for that great overview. So, trying to put this in my mind as a clinician, where do you see the role of our current understanding of the genetics of Brugada syndrome and, say, long QT? The clinical implications of that. Is there a role in screening patients using what we know about the genetics of these diseases? Is there a role in risk stratifying patients? And is there a role actually in treating patients based on our understanding of the genetics?
I think his last slide summarizes quite well this question. I think we have to be very careful. People that work on genetics should be very careful in translating knowledge into practice immediately, and to try to explain that genetics explain everything. In fact, if you do the wrong way, and you start with genetics, you are creating trouble. You're not solving problems. So you have to make sure that you understand what we are looking for in which patient, and then use the information you have to better treat our patients. But genetics has been very helpful in understanding what's going on, and I try to simplify it just to make sure that we will understand what we are talking about. But at the same time, we have to say that you have nothing you expect in human patient, and you expect that genetics will solve your doubts, that's completely wrong. It will create a lot of doubts. Because of course, if you do genetic on a sudden cardiac arrest victim without anything else, without knowing anything, you will have to. You will not know how to interpret it. If you start in this field, then you might start studying the son, the brother of this patient, of this son, their victim, and you will find it. And you don't have anything else to corroborate the diagnosis. You might be starting taking therapeutic decisions in people that don't think they have this mutation. And I always say to my patients, I don't treat mutations, I treat patients. And we should stay away from mutations, because we still don't know anything, or we don't know enough of all the conditions of who is solved. In Brugada syndrome, in short QT syndrome, in long QT syndrome, despite some previous publications showing that genetics could help in risk stratifying, genetics does not help risk stratifying our patients. It helps in the diagnosis, yes. It can support the diagnosis. If you have a patient that you need first the patient, and you need a long QT, or you need whatever in the patient, or you need symptoms, or you need what doctors do to make a diagnosis. And then we use the genetics as a corroboration of the diagnosis. It can help certain, clearly, if you have established the diagnosis of a disease in a given patient and you have the confirmation of the genetics, the last slide, without any doubt, it is the most useful part of genetics. It can confirm or exclude the disease in the family members of this patient. So you have a son If the father has a disease, whatever, clear disease with a confirmed mutation, if the son doesn't have a mutation, he doesn't have a mutation.
Can I follow up? And actually, also for Dr. Aziz, sorry that for genetics, for clinically, is for family history of sudden death in somebody with Brugada syndrome or long QT, or with other hereditary conditions like hypertrophic cardiomyopathy, where family history is an important prognostic marker, whereas in Brugada, at least from what we know in your company, it doesn't appear to be a prognostically important factor. So how do you explain that for all these hereditary conditions, family history of sudden death, even multiple family members, can be a prognostically important factor in one condition, but in another condition it doesn't appear to confer any additional risk?
That's a good question. I think we have to be careful about the meaning of family history and the importance translationally. I think the family history is focused upon to provide a diagnosis. Beyond that, particularly with most of the genome, with the ion channelopathies that we're talking about today and tomorrow, there's variable penetrance. So a gene mutation in a father is different than a gene mutation in a son. And I am a firm believer that a family history of sudden cardiac death in a father should not buy a son an ICD if it's even the same gene mutation. And that's not how I practice. Every single patient should be risk stratified individually. It's more difficult if the child is young, of course, but there are other ways to do it, I think. And in regard to the genetic testing as a screening measure, it really does depend on the disease, because each disease has a different signal-to-noise ratio, which is really the key factor. Signal is a positive gene test in a patient that has disease. Noise is the noise in the general population. For long QT syndrome, it's pretty good. Most of the other ones, it's not as good. So the threshold to do gene screening, I think, at least mine in long QT syndrome, is a lot lower than it is in Brugada, for instance, where the yield isn't as good, and you're going to get noise, and that can have family consequences. So really, it depends on a lot of things, I guess, but it's an important question to think about.
Probably two other comments. One comment goes, at least for Brugada. For Brugada, what happens when you put in perspective the family history? Two different aspects. When you put in perspective the family history, we published some years ago a study in European Heart Journal where we were showing that look at large what sudden death means when you put the history of sudden death in the family. It turns out that in families with Brugada syndrome, with non-Brugada syndrome, the part of the family that did not have Brugada syndrome or could not have it because of the transmission of Brugada syndrome, you could have at least 30% of the sudden death in the family. So you talk to guys that you have Brugada syndrome in the family, you have sudden death in the family, yes, and then you were looking at 30% of the sudden death could not be related to Brugada because it was in the other, in the non-related family. So you have to be very careful with that. Second, when we did the analysis of Brugada family, or of the Brugada history, the sudden death, family history of sudden death related to the presence or not of a Brugada, it turns out that we have realized that the majority of patients that is at low risk is the patient you identify because you do family screening. So now we know it's family history, now we know it's a family genetic defect. So you have somebody with a defect, and we push the diagnosis to others with isolate test. I have shown that you have a patient with normal ECG. It does not mean that you don't have it, but you are a very good prognosis. So we are identifying a lot of people that has family history and has a very good prognosis. So when you then look at the follow-up of the patients, which are the ones that have a family history of sudden death, they are very good prognosis. So it's the being part of the family with Brugada does not mean that you are at high risk, of course, because we are pushing the diagnosis in a lot of the members of the family. You don't do that in the general population. You don't push the diagnosis in the general population. You do it in the ones that have a family. So and then you are confounding the result because you are increasing the number of very low risk patients in those that have it.
I have a question, actually two questions if I may, while people are thinking. The first is that both of you have shown us that defining the genetics actually helped us to understand the mechanism of the disease. And the next step is to try and evolve patient-specific therapies. And how near are we to this, and can we, by looking at the different mutations producing different gain of function or loss of function, can we do that, for example, by generating IPS, or how good are the animal models in reproducing the disease and then evolving patient-specific therapy?
A good example would be short QT, because short QT, you can very easily imagine that what you are having is a gain of function of some channels. We rarely have drugs that enhance the channel, but we do have drugs that block a channel. So we could imagine very easily that you can have drugs that block IKR or IKS specifically, and that would normalize the QT drug. Well,
okay, what about animal models? You talked about animal models quickly,
right,
but...
Of course, you need animal models, and you need to modeling, and you have to do if you do modeling and you simplify the things, it turns out that you say, okay, I have a mutation that is producing a gain of function of IKR, so if I give a drug that blocks IKR, I will normalize it. In the modeling is true, in the reality is not true, because the patients that have been tested so far with shuttle or whatever, you don't get that. But on the contrary, again, we have this magic drug, which is quinine, which we don't know why is the only one that is able to normalize the QT interval or to prolong the QT interval in patients with short QT. So we are still far from understanding everything, very far. So we try to simplify, which is good. We try to understand, which is good.
It's moving
in models,
yeah.
and because we are creating the models, we trust what we model, and of course the model will do what we are doing him to do. But in reality, biology is very complex, and biology is a mix-up of things, and we are still far. Of course, we all would like to say, hey, mutation-specific therapy, you know, but still, we are far. We know something about mutation-specific therapy in the long QT3, for instance. No? You look at long QT3, you do a sodium channel blocker, you normalize the QT interval. You take Brugada, you give the same drug, proteinide, and then you will create more anomalies. So it's true that there you can manage. Let me make a joke, because this is a joke that was done by one of my bosses in France many years ago. Once I presented him the long QT3 and the Brugada syndrome, and then he said, "You long QT3, the sodium keeps getting into the cell. The Brugada syndrome, the sodium closes before it should. The long QT are usually young females. The Brugada are usually middle-aged male. Why don't we marry the middle-aged male with the male, and then the boy will have normal QT."
A social treatment. Okay, any question? It's your chance. Yes, good question, please.
Thank you for this wonderful presentation. My question would be always more on the research side of the talk. I'm not an MD, so I'll be really focusing on research. When you showed your action potential, actually your action potential was mainly composed of sodium channels and potassium channels. As you know, one of the main important channels in the heart is the calcium channel. And if we play with calcium channel and calcium content in the cell, that's what will create arrhythmia and perturbation of contraction of mass. So what is the status of calcium channel perturbation in the Brugada syndrome? And second question, very quick, is what do you think about activation of PK pathways and phosphorylation of sodium channels and potassium channels in the Brugada syndrome? Which means you can basically cure people or improve their state by just modifying PK, activating or reducing the PK pathway activity. Thank you.
For Very dangerous. But the calcium channels, we know that, as you say, calcium channel, of course, plays a major role. I explained already for the ryolesin receptor and polymorphic community considered like that. There's also for Bugada, because it has been shown, also for the short QT, he has shown that the short QT 4, 5, and 6 are calcium channel related mutations. But some of them are related to Bugada. So there is a combination of mutations in the calcium channel that produce a short QT and a Bugada phenotype. And you have shown one example in this presentation. So I think that, of course, that reflects what I'm saying all the time. I mean, that we try to simplify it, to make it simple for explanation, but this is not what we should use to translate it immediately to clinical practice, because we will be wrong. We will not be doing the right thing to the patient, so we will be simplifying, oversimplifying things. And at the end, why quinine seems the magic drug for all that? Because probably it affects a little bit here, a little bit there, and a little bit there, and it normalizes almost everything. And then it looks like it works almost for everything. So I think this is the second question. I really don't have the answer. I don't know. I hope you will give the answer. I mean, the people that is doing basic research will do the answer, and will have the answer to all these questions that, of course, we'll need. We still don't know. But what we can do is not, and I think it's very important, it's not to give a wrong message to clinicians. Not to give or try to transport to clinicians the message that we know everything, genetics solves everything, do genetic testing and we will have. Do genetic testing and we will have a lot of problems.
Say thank you. Thank you very much indeed for outstanding 2 lectures.